Well, I guess we'll get started then. So thanks, Sissy. So for our non-neurologist specialty corner for NCS 2020, we invited 3 non-neurologist neurointensivists to share their experiences about their career choices and trajectories. And each of them has had a very different career pathway from training to first and second jobs, military career for one of them, and then a bit of a pivot for another. So it's interesting, I think, to share those journeys and that pathway so that people who are coming up through the ranks who are not neurologists recognize both the opportunity and potential pitfalls of being someone who's not a neurologist in our specialty, and recognize that our ranks are growing pretty continuously year by year. The Neurocritical Care Society saw fit to create this specialty group for us because there are enough of us now that we need representation. And our needs are just a little bit unique, not dissimilar to other subspecialty groups within the practices. So if you guys are willing to share, I'm sure that everyone would love to hear your story. And the fact that we can record it and share it in perpetuity just makes me happy. If it is okay with you, we're going to do Dr. Fontenette, Dr. Zamet, and then Dr. Garvin kind of in that order. I will turn the screen sharing off here. Rod, if you got slides, let them rip.
Here.
Oh, man.
Ooh.
Whoa. Whoa.
Wow. And I'm done. Any questions?
The mic drop there.
Yeah, so thanks, Jordan, for the intro. So I'm Rod Fontenette. I'm one of the active duty Air Force EM intensivists. My path, as Jordan kind of alluded to, is a little bit different in that I am active duty Air Force. I did a traditional 3-year EM residency program, followed by a 2-year multidisciplinary critical care fellowship. It's not a I did not do a neurocritical care fellowship, but a 2-year multidisciplinary fellowship with IU Health, Indiana Health University, Methodist Hospital in Indianapolis. So being that I am active duty Air Force, I just kind of always have to like to include a DOD disclosure statement stating that all of these things that I'm going to be talking about, though it will be heavily focused on my military career and experience, the DOD does not endorse any specific product or thing over anything else. So this is Rod's career path and what I did to get to where I am today. So let's talk about like where this all kind of started from. So as I alluded to earlier, I did a 3-year EM residency, followed by a 2-year critical care fellowship in Indianapolis. Following completion of my fellowship in Indianapolis is where I met Jordan, Bill Knight, and the rest of the team, Opwe, in Cincinnati, where I spent about 3.5 years at the University of Cincinnati, spending time in the emergency department, as well as the neuro ICU, a couple of weeks in the SICU, but the majority of my time was spent in the neuro ICU when I wasn't doing my primary job for the Air Force. That job in the Air Force was as an instructor for the we call CSTARS, which stands for the Air Force's Center for Sustainment of Trauma and Readiness Skills, basically teaching folks how to adapt clinical skills either in either Black Hawk helicopter or some type of rotary wing helicopter, or in a fixed wing platform like a C-130 or C-17, 30 to 35,000 feet in the air. So this is one of the helicopters here we used when I was in Afghanistan in 2014, flying with dust off. And again, taking those skills from the bedside and adopting them and using them kind of in this very confined, tight space. And what we do is traditionally, we follow what we call CPGs, or clinical practice guidelines, on managing significant and severe traumatic brain injuries. In the military, what we've done is we began to focus more so on what we call mild traumatic brain injuries or concussions, because we're finding that quite a few of our soldiers, sailors, airmen, and Marines are suffering from mild traumatic brain injuries or concussions. So we began to kind of focus on those more so from the point of injury all the way till we get them back home. And again, operating in very tight, confined spaces. So taking the things that I did in fellowship and in Cincinnati and adopting those things to this platform. And then teaching folks as they come through our course. On my deployment in 2018, I was in the Horn of Africa in Djibouti. and I was out there with this, providing air support for some of the Navy SEALs and some of the missions that they were doing. And one of the missions we had was a point of injury mission, where a soldier had been basically received indirect fire. And there was a medic that was on scene. And when we arrived to pick the patient up from the point of injury, I couldn't tell that the patient either was suffering from a severe traumatic brain injury or he was just overly sedated, right? Because the medic was like, I gave him 150 of ketamine, 150 of fentanyl, and 5 of Versed. And that was all in like 5 minutes, right? So when I picked the patient up, he was kind of foaming at the mouth, unresponsive, and not really doing much of anything. So being able to take the skill set that we learned here stateside and be able to kind of, one, manage the patient appropriately. He got intubated almost as soon as he got in the back of the Black Hawk. But then take that information and train those medics to provide better care to those soldiers further forward, and kind of work through better ways to manage those patients. Another thing we did in Cincinnati at that course was those same type of patients, but now more so in a fixed wing platform. This is Chuck on the left, Dave on the right, in our simulation center. And as you can see, Dave on the right has a Kerlix dressing on his head, and he also has an EBD in place. So training on how to manage these patients with traumatic brain injuries, fall forward 35,000 feet in the air. And there are quite a few things that we still don't know from the military side of things that we're currently researching, i.e., when is it too soon to fly these patients with traumatic brain injuries? These are things that we just don't know. Even though it's a pressurized aircraft, pressurized at about 8,000 feet, we still don't know, is it too soon to fly these patients? What we do know, though, is leaving them fall forward probably isn't in the patient's best interest, because sometimes we only have a certain window that we can move these patients, and leaving them there for days on end probably isn't in their best interest when they don't even have CAT scanners fall forward. We've kind of, the Air Force, I think, has done a very good job at deploying a lot of these teams, even some of these teams on rotary wing aircraft with ultrasound machines. So we've been teaching folks how to do things like optic nerve sheath diameter and things like that, fall forward, since we don't have CAT scans until we get back to places like Bagram in Afghanistan. But these are things that we're taking from the neurocritical care world and pushing fall forward to just kind of adapt to our environment. And then we teach folks how to do this all under low light or green light environment with noise while things are kind of moving around quite a bit. And these are the platforms that we use, either C-130 or C-17. Again, in a very cramped space with a lot of things going on all at once. I left Cincinnati where things were kind of well established from an emergency medicine intensivist standpoint in the neuro ICU. And the Air Force has moved me on in 2017 to UC Davis in Sacramento, California. And it's like night and day different, right, in terms of things being already kind of in place. When I got to UC Davis in, I think, March of 17, the system was trying to stand up their neurocritical care service prior to me arriving, and then 2 actual neurology trained neurointensivists from UCSF. The pulmonary critical care folks, for the most part, covered their neuro ICU patients. When the 2 neurology trained neurointensivists arrived, they named one of them kind of like the director of the neuro ICU, and they began kind of like moving folks out of the neuro ICU so that way they can kind of take more control of the unit. And then there's Rod, right? An EM trained guy that doesn't kind of fit into any one of those spots. I was the first EM intensivist at UC Davis. In 2018, the second guy, Matt Greer, he arrived. And out of the 2 of us, I'm the only one that have been able to get into the neuro ICU. And even though I've been there for 3 years now, I've only been able to get into the unit as of May of this year. And I think the reason for that is because UC Davis was trying to get their comprehensive stroke center certification. And one of the stipulations is that they needed someone that can consistently be there to help cover their nights. Hey, Rod, what are you doing? I know you've been trying to get into the neuro ICU since 2017, but we got a spot for you. How about a bunch of nights in the neuro ICU to help get our certification up and running? So in comes Rod, and I've been helping them on nights since like May, June timeframe, covering some of their nights in the neuro ICU, hoping to get more of a footprint established in the neuro ICU and kind of go from there. Things that I've done to kind of help bridge that gap is working with some of our EM residents. We do not have a neurocritical care rotation as part of our EM residents rotations. And because the neuro ICU is still fairly new for what they're building, what I'm offering them is to get EM residents into the unit. We began covering more things like TBI management, targeted temperature management, post-ROSC, because believe it or not, most of the patients that come through the emergency department right now do not get cooled and put on targeted temperature management, whether they meet criteria or not. The vast majority of them don't. So these are things that we're doing to bridge the gap: stroke management, seizure management, kind of bringing that care from the neuro ICU down into the emergency department. Again, kind of building that relationship and building that bridge is what I'm kind of doing to kind of, again, increase our presence in the neuro ICU. And then hopefully I'll be able to go more onto covering day shift for them. I've only been able to cover one day shift so far since I've started this whole process. I've also created a 2-week EM neurocritical care rotation as an elective, again, trying to increase our presence in the neuro ICU. So it's been a little bit different from my time at University of Cincinnati, where things was a well-oiled machine, things were going great there, to now transition over to UC Davis, where that presence of an EM intensivist, one, wasn't even at the hospital until I got there in 17, and two, it definitely wasn't in the neuro ICU. So basically kind of trying to establish things from the ground up. So far, I've been helping them teach ENLS and other things like that. So far it's been working out well. I'm on nights now, and hopefully here in the near future, I'll be on days. But I do see that happening here in the near future. So, and on the military side of things, again, taking things from fellowship in University of Cincinnati and UC Davis and pushing them far forward. How is that helping us in terms of our neuro trauma on the military side of things? But what we do obviously make a difference, right? So survivors of folks with GCS of 9 or less than 9 that were able to progress to independent living, 40% of those folks that have a GCS of 3 to 5 were able to progress on independent living, and 60% of those folks with GCS of 6 to 8, which is huge, right? So again, that's because we've taken these things from lessons learned from neurotrauma and literally pushing them far forward to point of injury. If you look back at literature from like Vietnam, it would take almost like 2 to 4 weeks to move patients from the point of injury back to the United States. Now, on average, that's taking about 4 days, right? So again, we're moving these patients, and these lessons learned from things we're doing in the neuro ICU bedside here in the US and pushing them far forward to tell soldiers, sailors, airmen, and Marines far forward, it's paying off huge. And it's starting rehab sooner than later as well. So, and then we get to hang out with these guys here in the back of helos, kind of playing around with those guys. And then John asked me to make sure I had a picture here of me hanging at the back of a Black Hawk, and there I am in Afghanistan hanging at the back of a Black Hawk. So again, getting to do cool guy stuff. So that's all I have. Thank you kindly.
Rod, thanks a lot, man. I appreciate you talking about it. I think it's particularly interesting for me to hear the part where you describe being a seasoned neurointensivist, landing at a new shop and having to sort of fight your way down the beach again and create a space for yourself. It's interesting, especially because I know during your, it wasn't much of a recruitment, right? You got reassigned out there. So you didn't probably have a whole lot of opportunity to talk about it before you got there, although you probably made some inroads. But it is really interesting, and this is something that we've heard before from other seasoned EM-based and non-neurologist neurointensives, where they go to a different shop and it takes them a while to fight their way in, and they don't want to be difficult, right? They don't want to be seen as the enemy at the gate. At the same time, they have a skill set to bring and they want to use it. What were your conversations like when you were trying to get in? How did you convince them that you could really do what you claimed you could do as a neurointensivist?
Well, so one of the things, great question, right? So one of the things that I did when I first, so even before, you're right, even before I got to UC Davis, I flew in, kind of met with the ED. I spoke to the chair of the ED, Nate Cooperman, and said, hey, look, this is what I kind of bring, right? So obviously I want to do emergency medicine while I'm here, and the Air Force has me here as the associate program director for the military emergency residence. That's my primary job. However, I'm also an intensivist, right? I told myself, look, for the past 3.5 years or so, I've been in the neuro ICU more than any other unit at University of Cincinnati. So that's kind of where I would like to head here. They said, well, things are kind of still developing in our neuro ICU, and I'll put you in touch with the POEM guys, POEM critical care guys that are covering. So I met with them, Hugh Black, Chris Sabat, all those folks who are the two primary ones in that group that had done the neurocritical care exam. They were certified in that. So I actually met with those two guys when I went down just to visit. And they were like, hey, we have no problem with you coming into the unit, but just so you know, we have two new folks that are coming, so that are neurology trained neurointensivists. And at UC Davis, the two neurology folks fall underneath the Department of Neurosurgery, right? Not neurology, but neurosurgery, right? So some of the issues that we've been having here, even with our pulmonary critical care guys that have been covering the neuro unit for years, even they, like the neurosurgeons, are like, we want our neurology trained neurocritical care folks to handle all of our neurotrauma, not the pulmonary critical care guys. Despite the fact that you guys have been doing this for years, we still would prefer to have these guys covering it. So even they have been, those two guys, Chris and Hugh, have been kind of getting pushed out of the unit. Yeah. So that's becoming a problem in and of itself. So what I'm doing is teaching more. Like for instance, this Friday, I'm teaching ENLS to the neurosurgery folks and to the neurology folks. So proving to them that, hey, I know what the hell I'm talking about. And then now with me covering nights and them seeing me how I'm working at night and see what Rod has to bring to the table. Now they're like, hey, I have jury duty. Are you able to cover for me on days now? So again, here comes Rod, right? So again, just slowly starting to inch my way more and more into the unit. And I think that's starting to help a bit.
Thanks. And I just got to share, I mean, the story that you just shared in particular about established non-neurology based neurointensivists being pushed out of their unit when neurology trained neurointensivists come in is a story that we have heard in a number of larger East Coast centers over the last decade or so too, and was the impetus for the creation of this group a few years back. Rod, thanks so much for sharing. Dr. Zammit, you also have a slightly different career trajectory than many, and I think we'd all love to hear what you got to talk about.
Yeah, no, I appreciate you having me follow Rod, who's like a supremely superior storyteller to myself. That was awesome, Rod. I don't even want to talk. I just want to let you keep talking. That was awesome. That was a great. That was awesome. I really appreciate you sharing all that. That was well told. So I mean, I think that one thing that they obviously from a panel standpoint comes. I think one thing we all have in common is that at some point we passed through the University of Cincinnati. So my journey began. I did my 4-year EM residency at the University of Cincinnati, and then from there I went on to do neurocritical care. I went over to the New York Presbyterian program in New York City, which is it's mostly based at Columbia, at the Columbia shop, but somewhat at Cornell as well in New York City, which was definitely a bit of a different experience for me. That was my first foray into sort of stepping away from where University of Cincinnati, where most of the acute neurologic services had been really split between EM and neurology or neurosurgery. And in New York, it had always been very neurology based. The fellowship there has been in existence for a long time. And historically, I think when I did my fellowship, it had been in existence for about 15 years. I was the third non-neurologist to do it. The first was, if I know my history there correctly, it was Dave Cedar, who's an internist, who's now up in Maine. And the second was Cappy Lay, who he did his actually through like a joint grant from the state of New York. Actually, it was kind of an interesting way that he did his. And then I followed behind him. An interesting part about that is that the neurocritical care fellows there had always been kind of viewed as being sort of the house staff neurologist, or the neurologist is sort of in charge of Columbia Presbyterian Hospital at nights when everybody went home at about like 5-6 o'clock. And when we were covering the neuro ICU at night, if one of the neurology residents had a neurology question about a new consult, admission, a patient on the floor, that was the purview of the neurocritical care fellow. I didn't know. I wasn't as aware of that when I had elected to pursue that and match there. But that was definitely a steep hill to climb for me for starting it off. But it was good for me, obviously, but get me outside my comfort zone, and I certainly learned a lot more neurology as a result of that experience. Also, while I was a fellow, I wanted to maintain my EM skill set. And it was kind of complicated, actually. One of the things, I guess, if I were to speak to trainees doing neurocritical care, is my position at New York Presbyterian was an ACGME funded position. They actually used vascular neurology money to pay for the position that I was slotted to. So therefore, within the entire New York Presbyterian hospital system, I was a GME officer, not a medical, not part of the medical staff. So if I worked in the emergency department, even though I would have to actually be signed off. All my charts have to be co-signed by one of their actual attendings in the ED. I was like, well, I mean, there's a pretty good option a little farther west. So I actually ended up coming back during some of my elective time as a fellow, and did some attending time at the University of Cincinnati at University Hospital to maintain my EM skill set. And after my fellowship, that was where my first job was. So actually, it's when I met Rod. I was one of the EM intensivists there who split my time between the neuro ICU and with the emergency department. I was fairly involved with critical care transport, so I did a little bit of flying with the air care as well while I was at University of Cincinnati. And then I got recruited from there up to the University of Rochester. I'm originally from Buffalo, New York, so it was an opportunity to get a little closer to home. My position at University of Rochester was probably where I think I probably grew my wings a little bit. I think that my first position being back at the University of Cincinnati, you're sort of trying to grow up in your father's house a little bit. And I was part of a large pedigree, I mean, in Cincinnati, whereas at the University of Rochester, I was the first person to really be sort of dual trained and living on both sides of things. I was fortunate at the University of Rochester that the folks who were particularly interested in recruiting a EM neurointensivist was actually the Department of Neurosurgery. So neurosurgery was heavily involved in my recruitment up there, and as well as neurology. So that definitely helped, I think, me bridging some of those departmental challenges that can exist when you're living in one space but then working in another space, when those paths haven't been treaded. I think that was something that honestly I was aloof to or naive to in Cincinnati. That was work that had been done 25 years before I was faculty at University of Cincinnati, with the way that there has been this collaborative setup from the stroke team to the neuro ICU between the Department of Emergency Medicine and the Department of Neurology there. And so I was the first person to sort of begin to delve into that. And so it was hugely rewarding. There was a lot of opportunity to begin to bridge some of these gaps, both within the hospital, but then also within the entire region of care. Up in upstate New York, there was a couple of major health systems that provided advanced neuroscience care, whether that was comprehensive stroke center level care or even neurotrauma related care for that upstate New York region. And again, I was in a unique position where I had this experience with critical care transport, with emergency medicine. And again, my training in neurocritical care happened to be one where I learned a lot of neurology and and I did a lot of acute stroke in my training. So that lended me to doing telestroke and helping to set up a mobile stroke unit at the University of Rochester. So it was really fun to bring a lot of that education to the emergency department. My first year there, we started to, I think as Rod mentioned, we started to have the EM residents rotate through the neuro ICU. My first year as faculty there. We did just a lot more cross training between the two environments. By my third year there, some of the EM residents were even doing 2-week stroke electives on the stroke team. It was a good experience, and I'll be honest, it was also eye-opening to me because frankly, when I got to the University of Rochester, the emergency department's role in the evaluation of acute stroke patient was pretty small. It was really just making sure that their airway wasn't compromised, but it was mostly left to neurology and neurosurgery residents to really run the rest of it. And like I talked about the history of University of Cincinnati, where as an EM resident, we ran those and then talked on the phone to the person covering the stroke team and did probably good 70-80% of the work. I felt a lot more primed coming out of my EM residency to handle 60-70% of the strokes that would come in, even independently. But I think with the University of Rochester, it was pretty rewarding to try to help to kind of increase the emergency medicine residents' role in those patients, in the stroke patients evaluation in the ED. Well, I was there. I got super busy with clinical trials. I landed up as the PI for the Boost 3 trial there, for the CHARM study, and then I was the PI for most hadn't started yet, the most trial as well. So just trying to expand the clinical trials platform particularly for the acute neurologic emergency phase of things, the stuff where we had to get people enrolled within 6 to 12 hours of arrival. Similarly for cardiac arrest as well. So kind of again, a lot of the same stuff that Rod was talking about, just trying to bridge those gaps even from a research standpoint. So then kind of unexpectedly, I got recruited back down to a position in Cincinnati. So it's my third tour through Cincinnati. I'm a hockey guy, so I guess I had to get the hat trick. And I mean, I found myself at a health system in Cincinnati called TriHealth. The position I was being recruited for it's a multidisciplinary critical care position. I will say that for me personally, when I ventured into neurocritical care, I was very, very interested in and very motivated by neurocritical care, but I also enjoy the idea of being an intensivist and be able to work in different units. So this was an opportunity for me to work in different units. That was one of the challenges I would have had at University of Rochester of trying to break into some of the different ICUs there. It was a pretty crowded platform between the anesthesia intensivists, the medical intensivists, some of the surgical intensivists who all were trying to get time in the ICU. So the opportunity with TriHealth was I would do most of my time in the neurosciences ICU, and then also work a little bit in their cardiovascular and their med-surg ICUs as well. And it was also an opportunity to be the medical director for neurocritical care, and also for the title was acute neurologic emergencies, which basically helped to steer all these different disease processes, status, cardiac arrest, TBI, stroke throughout the system. TriHealth is a pretty well integrated system of care where many of the providers work at all the different sites. We use order sets, procedures, processes are meant to be pretty similar across the site. So it's more of a it's a role that's more helping to shepherd the system-based care, which again was what I had been doing in Rochester. I think that after my first 5 years in medicine, I think the things that I found that really jived me were clinical care, teaching, clinical operations, and particularly working with the system of care, trying to host some clinical trials within that system of care that I was operating. And that's kind of exactly what the mission of TriHealth is in that regard. And so it felt like actually a pretty darn good fit. I do miss neurotrauma. I do miss a bit of the academic sort of like banter that occurs when you're in a heavy academic site. Teaching to me is no different. We have a lot of APPs that we teach. We have residencies at TriHealth, and the residents are now rotating through our neuro-ICU as well. So definitely still the opportunity to do teaching with the residents. And of course with the nurses, doing some pre-hospital education, all that kind of stuff. So a lot of the teaching that I'm doing right now is very similar. We have a Grand Rounds platform that I've spoken at a few times. We do clinical trials. So it kind of satisfied a lot of the stuff I was doing. I think it was something that I was honestly coming out of academia, especially when you come out of a place, from my places like Cincinnati and Columbia and Cornell. I think it's hard to realize that there's as much as some of those scholarship activities occurring outside in these other environments. And I was, I think after 5 years out, I came to discover that. So for me, it was something that has become, struck me as a good balance, and so far so good. I did jump into a pretty challenging position. When I was joining the group, the hospital, Good Samaritan Hospital, had already put an application in to become a comprehensive stroke center. So when I had started the job, we were 2.5 months away from the site visit from the Joint Commission. And kind of my responsibility was, hey, you're responsible with this person, who's our stroke coordinator, to get the certification. So that was a pretty interesting hill to climb. Again, being a non-neurologist, basically appointed by the hospital system to be serving as the medical director of a comprehensive stroke center. But it stuck. So we got the certification. We've been a comprehensive stroke center now for, let's see, it was, man, everything is flowing by. So I think officially we've been in Comprehensive Stroke Center now for about 10 months, 10 months. So yeah, it's been interesting. I'm learning a lot about healthcare administration, healthcare operations, those kind of things. Yeah, yeah, it's again, it's sort of like almost surreal to be a non-neurologist with it. And in the environment I'm in, I think the academic environment, I think everybody was used to a neurologist doing it. I think I was a little bit just lucky in the position. Part of it is that the CMO of the hospital system was one of my mentors when I was a resident, and so I think that's why I wouldn't say that it's probably to be expected that a non-neurologist would land themselves in a position like mine. I think it's mostly because the CMO of the entire hospital system is somebody who's known me for 13 years very well, and so I think with that kind of history, I think obviously he was able to know me a little better, and I was able to slide into that slot.
Thanks, man. Sounds like it was a really interesting start, right? Coming into a comprehensive stroke center certification process. That must have been kind of a kick in the pants. When you stepped into that new environment and you went from like classic academia to classic academia and then into more of what I think many of us would consider a private academics environment, where private healthcare system with some residency training programs. Did you have any difficulty adjusting to sort of any of the differences between like a true academic environment where you're expected to do like, high level research and publish and stuff, to where you transition to the more private academic environment where your focus becomes teaching, maybe a little bit less research, and then this massive administrative role? Did you see any challenges to that? In fact, specifically by not being a neurologist, were there any issues that popped up for you?
I mean, I think the biggest thing that I was kind of concerned about going into it was I wasn't being hired into a position that had a historical presence in the hospital system. I was being hired into a position that really hadn't existed before. And I think my expectation going into it was that when a position doesn't exist, it's usually because a lot of people who are currently there and who were there before didn't think it needed to exist. And so I think the biggest challenge was knowing if I could earn the respect and the collegiality from the people that I would be working with to co-manage the patients. I mean, I went into a model where they were, they've been largely taking care of some pretty sick stroke patients without anybody with any real neuroscience training. They had no vascular neurologists hired in the system. They had nobody with any neurocritical training whatsoever in the system taking care of the patients. And for a long time, they were okay with that. And so I think it was only with the introduction of a couple of external players into that mix where they said we needed to do this, and they were able to convince enough people to say, okay, we'll hire it. Again, that's why I think that the position that I'm in doesn't happen if it isn't for the CMO of the hospital system being somebody who identified that need and was able to make that happen. But I kind of knew that going into it was largely the position I was in was someone where my rabbi was going to be restricted to the system chief of critical care and the system CMO, but otherwise there's regional CMOs, hospital presidents, service line chiefs, medical directors. I mean, all kinds of people who none of them were at that previous to that. Going to administration, we need neurointensivists. We need more people with cerebrovascular training in our system. Nobody was saying that. So I think that was the greatest challenge I kind of saw coming into it. I'm not going to say that I knew what I was getting into. I think for me, there was a lot of I'm not sure what I'm going to be getting myself into. Totally. I think for me, I was a little excited to be in an environment where I can honestly focus a lot on patient care. And I think that part of it for me, I knew that I was getting into an environment where there's a lot of positivity among the nursing staff. So they were really excited about the direction of things. They were really excited about the direction of change. So I think as we know, I mean, we kind of say what we want to happen, but everyone else does it as a position. So I know even before when I had interviewed there, it was very clear that there was a lot of enthusiasm and optimism from a lot of those people who actually do the work, your nurses and your ancillary staff, to have this kind of expertise there and to be able to execute this mission. So I felt that was a critical ingredient that I thought that was able to help us be successful so far.
Well, Dr. Zammit, thanks so much. I appreciated hearing that. It's wild to sort of listen to Rod's career and your career, and obviously both similarly trained up front, very different pathways through fellowship and into the neuro ICU, and then now radically different pathways again. And speaking of radically different pathways, Dr. Garvin, in the last, 20 minutes or so of this, gets to share her career path, which started out like many of ours as non-neurologists and then took this super wild pivot. And I think we're all pretty excited to hear how things are going. And I like the white background. It helps highlight the fire smoke in California that you're dealing with.
Very funny, yes.
The mask. Anyway, Dr. Garvin, thanks so much.
All right, thank you. It's really interesting to listen to everyone else's stories because I kept nodding my head in agreement of so many different parts of like what Rod was talking about and what Chris was talking about. So it's really, really interesting, but I definitely have a little bit of a different path. You can probably guess from the title slide that I have. You can all see my slides, I can imagine. So I will not refer to this as the dark side because you'll see from how I present this that I don't consider this to be the dark side. And as Rod mentioned, the views expressed here are mine and don't necessarily reflect Roche or Genentech. So I definitely did not have the most straightforward path, even into my role as a neurointensivist. So I actually started out as a nurse. And I practiced for a number of years in the PEDS ICU and the PEDS emergency department in Washington, D.C., and realized during my career as a nurse that I just wanted to know more. So that prompted me to go to medical school. And, having always loved that fast-paced environment, that pushed me very much into emergency medicine and critical care. And so as many other people on this call, I did my residency training at University of Cincinnati and then continued on my fellowship there in neurocritical care as well. And Jordan was one of my senior residents and one of my attendings, so we have a long history. And then from my position in Cincinnati, I went to University of Texas, San Antonio, as they had a very young neuro ICU, and they were looking to expand from 1 neurointensivist to 3. And they also were getting ready to start an emergency medicine residency program. And so my thought was I can go out there and kind of be that bridge between emergency medicine and neurocritical care. So my academic life was actually very prolific. I had associate professorship in neurosurgery, emergency medicine, and neurology. And similarly to what Rod mentioned, in neurocritical care, I was housed under the Department of Neurosurgery. So I actually came in and was in that department. And I was considered 100% neurosurgery with my time in neurocritical care. But as many people who do neurocritical care and emergency medicine wanted to try to keep up my skills as best I could. So I did about 2 shifts a month down in the emergency department. And my call schedule was about 1 week every 3 weeks, 24/7. So during my time, I also became the division chief of neurocritical care. I also created and got accredited a neurocritical care fellowship, both through UCNS and CAST. I was involved in a number of speaking opportunities, both locally, regionally, and then got involved in speaking on a national level, doing a number of talks for ASAP. And then also became the chair of the hospital bioethics committee and a number of committees at the hospital. So I did a lot in academics, but there were definitely some bumps in the road, which will bring me to why I've changed paths. So what I loved about emergency medicine and neurocritical care and why I pursued those as my career previously, I've always enjoyed helping people. This is something I did as a nurse, and then again, really was into being a good bedside clinician and having good bedside manner. With the emergency medicine and critical care, it's all about critical thinking, solving complex problems, being very cerebral about your approach to everything, thinking really deeply into things, which I enjoyed. I always loved teaching, and so I continued that. In my academic career, I was teaching medical students. I created an EM rotation for the second year EM residents who rotated a month. Then I was the fellowship director, so teaching fellows and rotating fellows from surgical ICU and from the anesthesia program. I love being creative. With neurocritical care, there's not a lot that's strongly evidence-based, so it's a lot of thinking through the pathophysiology and figuring, is this going to work with this patient? Yeah, I think this will work. It makes sense. And also making a difference. You have the one patient where, you spend hours and hours trying to do what you think is right, and then seeing them come back a few months later and they're able to walk and talk and give you a hug and say, thank you for taking care of me. Really was important and made a big impact on me. But I had a lot of issues with what I felt clinical medicine became. So over the years, at least in my institution, it became more and more about the metrics, following the metrics, meeting the metrics, not meeting the metrics, what happens if you don't meet the metrics. It became more customer service oriented as opposed to I am the doctor taking care of patients. So the focus just seemed to change, being practice being told what to do based on what the administration wants and not necessarily what's good for the practitioners. Being overloaded with paperwork, charting, emails about coding, not coding right, how is this going to be billed? And so that was taking up more and more of my time instead of taking care of patients. A lot of discussion about, we should do this, we should do that in case someone wants to sue us or we do something wrong. We want to make sure to order every test just because. And then in the academic world, making tenure. So what do I need to do to get promoted? What do I need to do to get tenure? Even if it's not necessarily something that's important to me, it's this goal that I have to try to get to in order to be successful in academia. And then the last part that I think had the most impact on me was this idea that I was herding cats all the time, meaning that the world that I was living in academia just seemed to every year become more and more uncaring, people lacking professionalism, and just being a job people had to get through and not caring about their patients, caring about each other as professionals. And this actually really came to light for me about a year ago when my own family member became ill and was in the hospital, and I saw it in other institutions as well where people didn't have bedside manner, and really the sense of what medicine was about seemed to be lost. So I started wondering, what else is out there? Is there anything else that's out there? You go through medical school and residency and fellowship because you're going to practice clinical medicine, and you hear the stories about those that don't practice clinical medicine and they're kind of the oddballs or strange, or how can you spend all that time training to take care of patients when you end up doing something else? But I started looking at what other things were out there, and as it was about 2 years ago, I was approached during one of my talks at ASAP about being a speaker for Genentech on their speakers bureau and talking to different groups about stroke care and the importance of how we take care of patients. So I started doing a number of talks, and I really enjoyed getting out there and speaking to people and being able to put my own clinical spin on what I thought was important as a practitioner. And I was able to get major hospital systems to change how they evaluated patients in terms of looking at disability and things like that. And so I started wondering, could I be doing something where I'm making a difference on a different level? And about a year ago, almost a year ago, a position came about at Genentech for a medical director in their lytics division. And I decided to see what that was going to be about. Could I do something on a different level? And so what's really interesting, what's really interesting is I'm actually doing all of the same things that I loved about practicing clinical medicine in this new position, even though I'm not directly doing patient care. So I'm actively involved in clinical trials. I'm actually currently, I have a trial that I'm putting together from an idea based on my clinical experience and my subject expertise that's going to start as a phase 2 trial next year. I get to work with the marketing division to make sure that the information they present is medically accurate and that it's portrayed the appropriate way. I'm getting to learn all about how pharmaceutical companies work and how they do their job in a very ethically sound and patient-forward way. And what I really found, which surprised me, is that the company that I'm working for actually seems more focused on putting patients first than what I felt in the academic world. And so I'm getting to teach, I'm getting to solve complex problems, I'm getting to think critically every day, being creative, and being able to make a difference on almost at a global level with things that I'm able to do. So not what I would have expected when I first started in medicine as a resident and a fellow, but I'm really enjoying what I'm doing now in my new path on the dark side.
Whoa. I think that was a big surprise for a bunch of people who didn't know about your job transition and your recent pivot. I think it's pretty cool to hear that there's such parallels between the things you enjoyed about your life as a clinician and what you're doing now in industry. This was, this whole talk is predicated on non-neurologists in neurocritical care. So coming in as the director of a division of lytics as a non-neurologist, have there been any challenges or potentially even benefits from your training background that you bring to the table now that were either recognized before you got there or have become apparent since you've showed up?
Yeah, so definitely has been a benefit. When I was looking at the position, one thing that my group found very interesting is my background that is so diverse, that I have that emergency medicine and neurocritical care experience, because I'm able to bring expertise in a lot of different areas. So I've only found it to be a benefit in the work that I'm doing and the knowledge that I'm able to bring.
Is your schedule better now or before?
Oh, do you really want me to answer that question? I mean, I will say I'm busy. I mean, yes, it's a Monday through Friday position, but because of a lot of the work that I'm doing is global, I have very early meetings, like 5, 6 in the morning, but I can finish early and I'm never on call and I'm off every weekend. So kind of can't complain about that one.
So I know that a number of physicians who work at Genentech also do a small clinical practice on the side from just maintenance of skill set, et cetera. Is that something that you are going to be doing, or is that something that you have decided is not really fitting with your future anymore?
You know, I initially planned on doing some clinical practice on the side in emergency medicine. And as I got into my role, I decided that I did not want to do that. Number one, I'm so busy with what I'm doing in this position. And it's not that I don't miss patient care, but I don't miss what went along with it, which is all the reasons that I left that field. So I'm currently not planning on doing further patient care.
And I guess the last question I would have is, like, what's your learning curve been like? Is it like a vertical mountain that you're trying to hold on to for dear life, or is it something that was familiar enough from your prior background that it made sense and kind of see the pathway up the hill?
Learning curve has been extremely steep. I mean, I knew nothing about industry, biotechnology, that, you know, I was always a bedside medicine clinical teacher. I wasn't a researcher. So doing clinical trials, I've had to learn everything. I think I've read more in the past 6 months than I have like all of my residency and fellowship. I mean, I've had to do a ton of reading to understand what to do. So the learning curve has been really steep, but it's been super interesting, and I've enjoyed every step of it.
Awesome. Well, Dr. Garvin, thanks so much for sharing that. I think it's pretty cool, and you are, as I, at least as I know it, within this group of us, this sort of whatever we are, this band of undisciplined non-neurologist cannibals inside the society. You're the first one I know of who has made the significant pivot outside of clinical care to either a pure non-clinical role in pharmacy, in your case, or biotech, or even administration. So I think it's really neat, and I was hoping that your story might inspire other people to explore the things that this background particularly makes you suitable for. I think most of us look at our careers as either the next academic position or a transition into a private world or community, and we tend to think about ascending the ranks through administration. One day we might make it to be CEO of a healthcare system, and you did this other wild pivot, and you're going to cure a disease somewhere, and we're going to hear about you as you get your Nobel. It's pretty wild. Team, thanks so much for spending this hour and change with us. For those of you listening at home, each of the speakers, I'm sure, would be happy to have you contact them directly if you have questions about career trajectory and that sort of stuff, as would I. Sissy, any administrative stuff before we close out the recording?
Nope, I think you covered it.
All right, thanks so much for spending the hour with us. So, speakers, thank you for the effort and making time in your extremely busy schedules. Everybody stay safe out there.